Welcome to Tea Talks, everyone, where we, along with our trans-friendly specialist, try to decode all the aspects of transition. So, in this effort, today is with us one of the top gender reaffirmative surgeons of India, that is Dr. Richie Gupta. Welcome, Dr. Richie Gupta, to our show.
Thank you so much. Thank you.
Uh, I, I would like you to introduce yourself. So, can you please give our audience a small introduction about you and how long have you been doing SRS?
Okay, so right now I'm director and head of department, plastic surgery and gender reformation clinic at Fortis Hospital, Shalimar Bagh in Delhi. And I've been in practice since 29 years. And most of those years, I've been doing gender reformation surgeries nearly since the beginning. And to date, I have performed more than 3,500 gender reformation procedures. And we receive around 250 patients a year. And we have a gender affirmation team in place with specialties because no single specialty can do justice to the vast needs of these patients.
Yeah, that's great. 3,500 surgeries. That I don't know anyone else in India who's done so many surgeries for gender reaffirmation surgeries. And if someone wants to contact you or consult you, how can they reach out to you?
They can contact at Fortis Hospital, Shalimar Bagh, and the the reception will redirect them to my coordinator Nancy, and they can or you can contact me directly on WhatsApp. So I can answer a few basic queries directly on WhatsApp at my number. So that I've been doing. I mean, people keep on messaging me, and whenever I find time, I try to WhatsApp them. But if it's if too many details are involved, then yes, a formal consultation. Often patients ask uh, a specific aspect. The interesting aspect is the cost. They are interested in the cost, and rightfully so, also. But then questions don't end. One question leads to another, leads to third question, leads to fourth question. So, and then I get only a bit by bit picture of the patient. So I prefer to get a complete picture and inform the patient of the complete needs, the entire requirements that are involved, and whether the patient is ready to undertake the journey or not. And for that, a formal consultation is the best. So so you can have a formal consultation, a physical consultation, or a teleconsultation with me, or you can come to Fortis and have a physical consultation with me.
And how long is this formal consultation, and how does one book a formal consultation with you?
Uh, the consultation is about half an hour, and we can have a can book it at Fortis as you just displayed the banner there. At that number you can call, or you can call my coordinator Nancy at 8802460050, or you can book a teleconsult with me directly. You can drop me a WhatsApp message. My number is 98100 52755. You can uh, message me, and we can set an appropriate time for the consult. And the consultation fees is around rupees 2,000.
Okay. I think since it's a half an hour consult, I think it would be interesting for people to write down their questions before they meet you. I think in that
Yes,
way they
it's
don't.
very important, and also involve the any interested party. They would like to their partner or their parents, whoever interested, because they may also have questions. So,
Yeah.
so be prepared in advance. Write down your questions so that you can ask all of these. If you have follow questions, I am usually happy to answer them on WhatsApp as well.
Right. And how did you specialize in doing gender affirmative surgeries? Because uh, you've been doing it for quite long, and it's not been it's a lot of doctors did have a lot of stigma in these surgeries. How did you specialize in these?
Well, when I started out as a young plastic surgeon about 29 years ago, so I didn't know anything about gender affirmation surgery. Very few patients were there as well. So one day, a patient came and sat in the seat, and he said, "Doctor, I want to become a male." And I looked at him. He was taller than me. I said, "You are already a male." And he said, "No, I'm a female, and I want to convert to male." And I really didn't know anything about it. So, so I said, "Let me gather more knowledge." And meanwhile, you get these tests done out. And I read extensively about it. And one by one, we performed the procedures, the top surgery, followed by the hysterectomy and plasty. And at the end of it, when I read so much about it and presented that case at various meetings, etc., gradually my interest became multifold, and I started looking forward to this surgery. So we have built up from around 5 to 6 patients initially to now 250 patients a year. Now it forms almost 50% of our work, our surgical work at Fortis. Incredible.
Yeah, it is one of the pioneering institutes in India for transgender surgery. That's something I've heard for quite long now. And what are all the transgender surgeries that you do?
We do the entire spectrum, the male to female, female to male surgeries, the ancillary surgeries like FFS, thyroid chondroplasty, reduction, etc., voice change surgery, and the routine plastic surgery procedures that patients may require, like liposuction, abdominoplasty, rhinoplasty, etc., hair transplants. So we do the entire gamut, the whole range of procedures here.
Okay. So now these surgeries are not just surgeries, they are also legal requirements for these surgeries. So, for example, for something like vaginoplasty, what kind of documentation would a patient require to get a surgery from you?
Okay, so basically all these requirements, they seem initially extensive, but they are not so. They are all designed so that there can be a prolonged doctor-patient relationship, a consultation, a prolonged kind of a consult. It's not a momentary decision or a sudden decision that I'll recommend that, okay, I perform the surgery tomorrow. I have to fully understand that this is the correct, because we see a lot of other conditions like body dysmorphic disorders, and even in aesthetic surgery we come across patients uh, uh, who may have some other issues, and in them performing a surgery will be harmful to them. So so for that purpose, the World Association, Professional Association for Transgender Health, and Indian Professional Association also have come out with a protocol. And the WWAP seventh standards of care were published in 2011, and eighth were published this year only in September. So, as per the seventh standards of care, which we have been following, the patient requires an initial consultation with two different mental health professionals. Now, what is the job of a mental health professional? Basically, mental health professional talks with the patient, finds out that there is no psychopathology involved because he's trained to detect the psychopathology. Or if patient does have some illness, then that illness should be well controlled. And because there are see many illnesses like multiple personality disorders, etc. And patient can imagine that he has a different personality. So we have to, rule out those cases. That patient is a genuine case of gender incongruence, and it is a job of mental health professional to do that and to counsel the family, to find out that what is bothering the patient, to settle any issues before performing the surgery. Also, that patient fully understands what is going to happen when hormone therapy is given or when surgery is done, and so uh, Patient assesses that and then issues a letter which states all these facts, that patient has been in contact, that the mental health professional has been in contact with the patient and has fully understood the needs of the and patient can go ahead and uh, uh, yeah, and get the transition process started. So we recommend that at least two mental health professionals and from two different institutes, not part of the same team, to give more objectivity. If even in Fortis patient comes and we have mental health professionals, only one from Fortis and one from outside anywhere. Because there have been instances when someone can be accused of a bias, and it has happened. So we say that okay, get it from two different places, and so the incidence of regret. Besides that, we prefer that patient lives in the desired gender role for a period of around 12 months. In these 12 months, there are all seasons patient dresses for all seasons like a trans woman, summer, winter, etc. Will get acclimatized to these dresses and will have a good amount of role playing and with the colleagues in office and at school or college. Is a reversible which is important, and it the patient is able to realize that this is how she is going to live uh, from now onwards. There are two very important criteria. Third is a hormone therapy. Now, hormone therapy is not a compulsory criteria. So, what does hormone therapy do? Like, see, the hair, any male pattern hair loss is halted. Like the recession of hairline, which occurs in males, is halted. So, hair grows quickly. Then the skin becomes smoother, shinier. There's a 22% into the more feminine, into a more feminine nature. There is breast development. So all these help again with the patient's incongruence. The patient's dysphoria is abated. Patient begins to feel more in more adjusted to the new, more integrated to the gender role she desires. So that's why we recommend that patient should have hormone therapy for 12 months. But those patients who have medical issues, who can't take hormone therapy, or those who don't want hormone therapy for some reason, so this can be waived off because it's a not an obligatory. So these are requirements for any genital surgery. For breast surgery, breast augmentation, only one mental health professional consult is required. Not two. But we start to, because we are patient not in a single episode or a single thing. We have to deal with the patient for a lifetime. So we both the mental professions consultations are taken so that patient's file is complete and we can move forward. In addition, we also require a waiver of liability affidavit. Now, what is that? Now, this 100 stamp paper and it is notarized. Now, as per medical ethics, the surgeon is not allowed to remove normal body organs. Like in case of a trans woman, and testes are removed, and surgery does not. Our ethics do not permit if they are healthy. It is considered a grievous injury. So so that is what is basically mentioned, that patient identifying characters are mentioned, that patient is so and so lives at such a place, and and the patient has a gender incongruence since so long, and has taken advice of these medical professionals and has been diagnosed as a case of gender incongruence and is proceeding for surgery and gives us permission to basically remove the normal healthy organs, which will result in change in patient's sexual functioning. And these basically are the requirements that we ask from the patient.
Thank you, doctor. Now, these are for irreversible and breast implant surgeries. But what about FFS surgeries? Do you require the mental health professionals certificates for? that too?
For ancillary surgeries, these are not required.
Okay.
Ancillary
Thank you very
surgeries
much.
like FFS, hair transplant, rhinoplasty, and a forehead, etc. These are not required.
Okay. Thank you very much, doctor. Now, uh, what would be the average cost of these surgeries in 2022 or 23 in this time period, if you can suggest?
See, breast augmentation, I'm talking about costs at Fortis, which may be more than the costs that if done at a smaller institute or a nursing home. So at Fortis, the cost of a breast augmentation surgery is around 2 to 2.5 lakh rupees. This is because we use Motiva implants, which are made in US, and themselves cost around 80,000. Yes. So that is the cost of a breast augmentation. Breast can also be augmented who do not want a breast implant with the help of fat transfer, fat injections. We can take fat from other areas in the body and inject them into the breast. Usually, 2 to 5 sittings may be required. Each sitting may cost something like 50 to 60,000 rupees. Then the vaginoplasty we do by 3 methods. One is a modified penile inversion technique, um, our own technique, and we have published it in Indian Journal of Plastic Surgery in July this year. And uh, the other technique is peritoneal, and the third is a sigmoid. So, if you want, I can go into detail of these techniques. But the penile usually 2.75 lakh rupees, and the peritoneal costs around 3.5, and the sigmoid can cost around 4 lakh rupees at Fortis. The rough estimates. I'm usually not involved in giving the estimates. It's the billing departments.
Okay. Thank you, doctor. Among these different vaginoplasty techniques, do you have a favorite technique that you think is healthy for the patient, and why?
Uh, Ideally, the technique should be customized to the patient's needs. So, uh, amongst these, I can spell out the pros and cons of these techniques. So, the patients today opt for modified penile inversion vaginoplasty. The reason is that it's the lean is not touched at all, and no abdominal surgery is done, and all the surgery is done from below the perineal root. And normally, the in trans women, penis size shrinks because of hormone therapy, and less penile tissue is available. We have modified the technique now. We use another flap called a perineoscrotal flap that we have mentioned in our paper, and that forms 60% of the vaginal lining, and only 40% is formed by the penile flap. So we have a lot of extra tissue available, which we use from the, and usually a depth of 4 to 5 inches with the help of modified penile inversion vaginoplasty. Peritoneal vaginoplasty, uh, in this, what we do is we dissect all around, and the inner linal cavity, which contains the organs, is dissected. And then there are 3 or 4 different methods to do a peritoneal vaginoplasty. And then this lining is inverted out, and usually a depth of 6 to 7 inches can be obtained with a peritoneal vaginoplasty. And with sigmoid, one can attain depths of 8 to 10 inches also. And there are some patients who have asked for it, and we have provided them this depth around 8 to 10 inches. I mean, you can go for as per the patient's needs. The depth can be adjusted in sigmoid vaginoplasty.
Okay. And is there like something for a first-time patient who uh, wants a healthy vaginoplasty? Is there something that you think would be recommended, or is it also?
I usually ask the patients 2 or 3 questions. The first
Mhm.
question is the what is the depth that you want? That is very
Mhm.
important, because there are certain patients who would straight away say that we want a depth of 6 to 8 inches. For them, modified penile inversion vaginoplasty is not the procedure of choice. So we can rule it out straight away and talk of the options like peritoneal and sigmoid. So that is depth is very important. And second is the hair growth in the area, because below and anal canal there is a strip of 5 to 6 centimeter wide. We usually use that in our perineoscrotal flap for a modified penile inversion vaginoplasty. If there is hair growth, we ask the patient to go for laser hair removal 6 to 10 sittings before coming. Otherwise, hair can grow in the vagina in modified penile inversion. So, so these I ask almost all the patients.
Okay. Okay. Thank you, doctor. Now, how can one prepare their mind and body for such a invasive surgery?
That that's what I said, that the process is such that patient comes to us prepared, in the sense that our mental health professionals have already counseled, guided, and and let me mention here, before starting any hormone therapy or surgery, reproductive medicine has a lot of role to play, because today we ask almost every patient that we can preserve their and in case of uh, trans men, we can preserve for long time, and then can have biological children of their own later with the help of these techniques. So that is the first thing to do. Even before starting hormone therapy, one should preserve their sperms and ova if they desire biological children of. So that's what is important.
Okay. And you also told that some patients want fat grafting instead of breast implants. There are also a lot of
Yeah.
cases of something called as breast implant illness, which is also called as Asia syndrome. Is it something that's also seen in India, and how is the awareness about that in India?
There is awareness about it, and that is why often patients request us to that they want to go for fat grafting instead of silicon based implant. But let me tell you that today the incidence of anaplastic small cell lymphoma is very, very less, because we are using fifth generation silicon implants and we are using smooth implants. Initially, it was more associated with textured implants, which are a textured surface. But now most of the smooth implants. Incidence is very, very low, maybe 1 in 30,000 uh, implanted patients or so. And the patient is in regular check, then it can be detected and it is treatable. So yes, but those patients who still can go for fat grafting. Breast augmentation is procedures done even in cis women in all over the world.
Thank you, doctor. And what is the procedure in Fortis when from the admission to the surgery bed? What happens to the patient? Can you guide us through?
Okay, so I'm talking mainly about trans women right now. So
Yeah.
we usually provide a written estimate to the patient of the procedures, so the patient knows what to expect. And in case of peritoneal or modified the patient on the same day as surgery, usually 8 a.m., and the patient to fast overnight, so that patient is empty stomach when she comes, and and then surgery from 10 to 11 a.m., and surgery average time for modified penile inversion is 4 hours, and for it can vary from 6 to 8 hours. And then patient undergoes the surgery. The admission time for modified penile inversion is 3 to 4 days, and 4 to 6 days for the other two techniques. In case of sigmoid, we admit the patient 1 day earlier. What is the reason for that? Because that day patient undergoes a sigmoidoscopy. So to rule out any illness in the sigmoid colon, so that should not be transferred later on to the vaginal cavity, or that it rules out any illness, so that procedure is safe for the patient. This sigmoidoscopy can also be done at a different episode. I mean, before admission at a different episode, then also it can be done, and then patient will admit on the same day as surgery. And generally, at day 4 to 6, so most of the patients are discharged to home if they are living in Delhi or to near guest house if from abroad or from other states. We usually start dilatation at day 7, and we ask the patient to bring their own set of dilators, or we also have a few sets available to arrange. And we usually teach the patient dilatation when on day 7, and the patient is expected to dilate for 15 minutes around 3 times a day for initial 3 months, and after that frequency goes down considerably. So this is the regimen.
And about dilation, how will a patient, for someone who's stressed or depressed, will it have any effect on their dilation?
Yes, it can have an effect, and that is why it is important that mental health professional patient comes through a mental health professional who has either ruled out or treated the patient's anxiety and depression, so that patient is in a fit mental condition to undergo the procedure. And the second thing is that, you know, a lot of this depression and anxiety vanishes the moment a patient undergoes feminizing genitoplasty. Patients really tell me that they are liberated, that they are born that day, they are very happy. So a lot of the patients' depression is alleviated by the surgical process itself, and then they are able to enthusiastically dilate. Yes, pain is an issue. Some patients are very sensitive to pain. They may not dilate. So that is why for first few days we call them regularly, so that they are acclimatized and they are able to dilate. Some patients may have uh, neurological or other illnesses, like one patient, and the patient was not able to dilate because muscle weakness, and then that can really result in a poor result, because then cavity can collapse.
And in patients who have difficulty dilating, can a pelvic floor physiotherapist or someone help them?
Yes, yes, that can be done. A physiotherapist can greatly help.
Okay. And currently, among the community, there's a huge excitement about peritoneal uh, vaginoplasty. Is it a safe technique, and is there any long-term data how this tech? And is also misconception that is a less invasive surgery. What do you feel about all this?
Yeah, if any new technique comes, there is naturally a lot of excitement about the technique, and that is what is happening with peritoneal vaginoplasty. See, modified penile inversion and sigmoid are gold standard techniques. Today, we do the procedure. We can predict that this is going to happen on day 2, day 3, day 4, day 5, 3 months, 6 months, 5 years, 10 years. One can predict, and that prediction, because these are gold standard techniques and have been present since many decades. Same is not true for peritoneal vaginoplasty. It's a newer technique, and and though bowel anastomosis is not involved when we compare it to sigmoid, but it involves a lot of dissection of the peritoneum. But what is peritoneum? It is the inner lining of the abdominal cavity, and inside the inner lining are present all the vital organs. So our GI surgery team, which is extremely good, does a laparoscopic or a robotic dissection of these peritoneum, and then this peritoneum membrane is brought down. It is very thin. If you compare to sigmoid, it's got a nice wall, but this is very thin lining, and then this lining is brought down to the introitus area, and this forms the lining of the vaginal cavity. Now there are various methods to do it. Some call it pull through, peritoneal pull through. Some call it the pouch, and different surgeons do it different ways. Like I talked to many surgeons who do it. So there is a famous surgeon from Thailand. What he does is he mobilizes the entire peritoneum and brings down. So and brings it down, but forms the rest of the cavity with scrotal skin graft. So only upper 2 inches of the vaginal cavity is lined with peritoneum, and rest 4 inches is lined with the scrotal skin graft. Usually, most of the surgeons try to interdigitate some tissue. Like in our case, we use some penile flap or the penoscrotal flap to line, because we don't want pink mucosa at the right at the introitus. So for some distance, we try to interdigitate with the other tissue as well. And I mean, there are really many techniques. And I talk to surgeons, I find that uh, uh, there's no one technique that all of them use. They have developed their own techniques for this. And yes, long-term results are not available. And there is some change in lining which occur. And sometimes some areas do not heal and granulations also occur in this. So overall, long-term results are yet to be seen, but it is definitely a new technique, and we have been doing it.
Okay. And is vaginoplasty in general painful? How is the pain managed after anesthesia fades away?
The technique is called CSE. It is epidural anesthesia. So we maintain the catheter in the back of the patient, and through that medicine is given regularly by pump, the continuous infusion pump, so that there's no 72 hours at all. And after that, that is removed, and then pain has considerably decreased, and we are able to manage on regular painkillers. Generally, painkillers are required for up to 7 to 10 days, and after that, there is usually no need for a painkiller.
And what about the age of the patient? Does that affect a decision to take them to surgery? What is the oldest patient that you have operated on for vaginoplasty?
Okay, so see, the youngest is 18 years. Below that, legally we cannot do this surgery. It's not legally allowed. And the oldest patient that we have done is around 60 years, an Australian trans woman. So she had come for vaginoplasty. So I'm sorry, I didn't know the other part of your
Yeah, it
question.
was about the age of the patient. Is it okay for someone at that age to go through surgery?
Yeah, yeah.
Is it safe?
See, people differ in their fitness at different ages. At younger age, it's a very safe procedure to do. But at older age, illnesses creep in, like diabetes, hypertension, whatever occurs in the general population. Those illnesses can affect the results. So yes, at an elder age group, we want the patient to be optimized before going for surgery. Everything should be in control. Any thyroid issues, any blood sugar issues, any blood pressure issues, any cardiac issues should be well controlled before undertaking this surgery. But one very important thing is the BMI. The patient should be ideally within the ideal BMI, that is 19 to 24 is considered the ideal, and 25 to 30, 29, 30 is considered overweight. So we generally prefer a patient with a BMI of up to 30, not beyond. And we ask them to reduce weight, because increased weight can lead to complications. And this is not only true for vaginoplasty, for any surgery.
Okay. And again, about breast implants, coming back to breast implants, uh, do you recommend that people stay on estrogen, on HRT for some time to see their breast development and then go for breast implants, or is it okay to go even before any HRT?
See, the general consensus and general directions are that it should be, initially it used to be 18 months, but now a 12 months period is considered optimum to assess the increase in breast size on feminizing hormone therapy. Generally, it is seen beyond 12 months, no further increase occurs, even if you take it indefinitely. So we generally recommend the patient that yes, go ahead, take hormone therapy for up to 12 months, and uh, that is the breast size you are going to get. that is the maximum breast size you are going to get at 12 months. And if you are not satisfied, you can come back for the augmentation. But yes, certain patients are quite dysphoric, and they want breast augmentation earlier to this period, so we can go ahead and do it.
Okay. And in case a patient has had breast implants for quite some time and they want to get it removed at a later age of their life, was there is going to be a certain kind of disfigurement? How can the patient handle, or is there any option for them to be to look so that their skin is okay and not disfigured?
See, this is true for both natal women as well as trans women, because in natal women also there is an incidence, and in certain countries considered 1 in 4 women will undergo probably undergo breast augmentation. That is a very huge number. So yes, this is true for both natal and trans women. And once, if the implant has to be removed for some reason, then yes, there is disfigurement, loss of the projection of breast tissue, and the patient has to. I mean, uh, we have to tide the patient over for that period when the wound heals, and after that, patient can undergo either fat grafting or a reimplant if the patient so desires. You can take the help of padding and the other clothes and other 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 changes which can tide the patient over the period.
And is there any surgery like PLEP or something that can help to tighten the skin?
Yes, mastopexy surgery which can tighten the skin, and if there is especially if there is a loss of perkiness of the breast, if there is a ptosis of the, then mastopexy can be very useful to uh, not only to augment as well as to raise up the breast and the nipple areola construct to the correct correct site. So yes, that can be done.
And what kind of scars can one expect for such a surgery?
Uh, there are various methods for augmenting the breast with implant. The commonest method is inferior inframammary incision. It's about 5 5 centimeter long incision given below the breast, just below the breast, so that it can't be easy. Uh, even if the patient is naked, it can't be seen easily. Then other is axillary approach where incision is given in the axilla, and another is umbilical approach. But these have some drawbacks. Sometimes results may not be optimum with these approaches. There's also transareolar or periareolar approach through which also the implant can be inserted. So these are different things, but the commonest is the inframammary. It's a very safe and very often used procedure.
Okay. Thank you, doctor. And about the vaginoplasty, is there any bony limitations for the from the pelvic anatomy that in some patients that can limit their diameter of vagina?
Okay. Yeah. So there is a pubic tuberosity where the pelvic bones meet like this, and then there is a ramus which goes like this behind. It is called istiopubic ramus. So it goes like this, and the inter-istiopubic ramus distance for natal women is around 5.5 centimeter, and but in trans women it is 3.5 centimeter. It's narrow. So that is why we use only very thin flaps like penile skin flap or a sigmoid or a peritoneum for vaginoplasty. We don't use thick flaps like a gracilis, for example, in trans women. Though these can be used in biologic women and cancerous situations, it can be used. So the reason for using thin flaps is because already this dimension is pretty narrow. So this is the one bony limitation that can occur up to over 600 plus vaginoplasties. Only once it has happened that I found that to be impediment. Otherwise, generally, it's not an issue.
Okay. All right. And how long does it take for a complete recovery from vaginoplasty?
See, most of the wounds have healed by a period of around, if we come from the end of surgery, discharge at day 4, 5, dilatations, the catheter is removed from day 7 to day 10 anytime. And then most of the wounds have healed by, and patient is encouraged to walk starting from day 5 and can do household work by second week and can go for walks after 3 weeks and gymming at around 3 months after the surgery. Aggressive gymming and activity at 3 months after the surgery. Period is a transition during this.
Okay. Thank you very much, Doctor. You've answered a lot of our questions. Thank you for joining us and helping us to understand the various surgeries that exist for transgender people.
You're welcome. Happy to be here.
And thank you. And thank you, everyone, for joining us. We will see you once again next time with another informative live. Thank you. Bye.